All right. Good morning, everyone. Welcome to day 2 of our 2-day course. This morning, we'll start with our Pancreaticobiliary disease section. My name is Stephen Kim. I'm an assistant professor here at UCLA, and I'll be moderating this session. So it's an interactive case-based discussion. We'll have 2 general cases. One is the management of Hilar Cholangiocarcinoma, and the second will be ERCP tools and techniques in 2020. And here's our panel of speakers. It's a good-looking group up here at the table and on the slides. This is Dr. Muthusamy, Dr. Keswani, Dr. DiNorcia, Sedarat, myself, Dr. Thaker, and Dr. Issa. All right, so before we start, a few questions for the audience. So get your ARS. Do you guys have your ARS tools out? And this is helpful for us as speakers to get a sense of who does what in the community here and who does what amongst the audience. So how many of you perform endoscopic ultrasound? Yes or no? All right, so 12% of you guys perform EUS and 88% do not. All right, we'll keep that in mind as we go through these talks. The next question, do you perform ERCP? And again, yes or no. All right, so many more of you perform ERCP than EUS, so up to 39% of you perform ERCP. That's great. So of those of you who answered yes to the second question, how many ERCPs do you perform per year? Less than 12, which is less than 1 a month, less than 50, which is less than 1 a week, about 50 to 100, or greater than 100 ERCPs a year. That's if you answered yes to the last question. All right, so we have a good smattering of the different answers. I'd say most do less than 50, but more than 12 per year, which is great. And then half of you guys perform more than 50 a year, which is outstanding. All right, and if you do not perform ERCP, what is your technical understanding of the procedure? A, excellent, I used to do it but stopped. Good, I know it can be hard sometimes. Or poor, did you get the stone out or not? For those of you who do not perform ERCP. Okay, so a majority have a decent understanding of what ERCP is like, and then we have some on either side. Okay, great. So it gives us a sense because this pancreaticobiliary section can be somewhat technical at times and can be ERCP, EUS heavy. So it gives us a sense of what the audience is familiar with in terms of these procedures. So with that, we'll start with our first case. Okay, so the management of Hilar Cholangiocarcinoma. All right, here's our case. A 68-year-old man presents with painless jaundice. He has lost 15 pounds over the past 3 months. His buddies at his weekly poker game notice that he has become increasingly jaundiced. He denies taking any medications or supplements, and his labs reveal elevated liver tests, including a bilirubin of 5.9, an alk phos of 387, an AST of 74, and ALT of 92. He gets an MRCP for evaluation of his elevated liver tests and jaundice, and here's what you find. He's got dilated intrahepatic bile ducts diffusely. He's got a normal, thin-appearing common bile duct, and then a normal-looking pancreatic duct, at least on the MRCP. All right, so here's my mouse. There's the bile duct here, just to orient those of you who are unfamiliar with MRCP. And then here are the intrahepatic bile ducts that are very dilated in the liver. All right, so the question to the audience before our first talk, what is your initial approach for making a tissue diagnosis in this patient? A, ERCP with brushings, B, ERCP with biopsy, C, ERCP with cholangioscopy and biopsy, D, EUS with FNA, E, percutaneous biopsy, or F, any way possible. All right, so over half you picked ERCP with cholangioscopy and biopsy. It's great to see. And if you guys picked brushings, biopsy, and FNA, no one picked percutaneous biopsy or any way possible, which is great. All right, so to further discuss this topic, we have our first speaker, Dr. Muthusamy, discussing the diagnosis of the indeterminate biliary stricture. The issue is getting tissue. All right.
Thank you, Stephen. So good. I think you guys got the answer right. Now I'll sort of explain why that is probably the best answer. So diagnosis of indeterminate biliary stricture, the issue is getting tissue, sort of. And actually, I think the real answer is tissue's great, but your visual accuracy is probably the most important. So what is an indeterminate biliary stricture? It's really a stricture that has no obvious cause, like mass on imaging studies like CT or MRI, like Stephen just showed you, and usually has had at least one non-diagnostic prior ERCP with brushings, which is usually the first sort of sampling technique that's traditionally used. And again, there can be a variety of etiologies of indeterminate biliary strictures. They can be benign, including PSC, IgG4 cholangiopathy, or postoperative strictures. They can occasionally be ischemic or infectious, or even be related to extrinsic compression, like Moritzi syndrome off the cystic duct, or it can be related to more uncommon things like vasculitis, radiation, or portal biliopathy. But more often they're malignant, usually from pancreatic, bile duct, or gallbladder cancers, occasionally from hepatocellular cancer, and then less likely from lymphoma, and occasionally also from nodal metastases from other tumors. So just remember that 60 to 80% of indeterminate biliary strictures are malignant. So you really are trying to prove that it's not in these situations. And again, preoperative diagnosis is often needed to offer appropriate management and subsequent treatment. So why are these strictures difficult to diagnose? Why do we have indeterminate strictures? They're hard to sample. They're not easy to get to. There can be submucosal spread of cancers, so the surface may not actually carry the malignancy. They may not be diffuse, so they may be focal. You may get sampling error, and your specimen can be hard to get because of the desmoplastic reaction that occurs and biliary fibrosis. And again, some of the devices we have now aren't necessarily, it's not like we have copious sampling techniques, although we are getting better. And then biliary cytopathology interpretation is challenging, even at expert centers. So we have a whole bunch of options, many of which Stephen just listed to you on his multiple choice question. You have brushings, you could do a fluoroscopically guided biopsy, you could do cholangioscopy and then make your decision either based on what you see or by image-directed biopsies. You can use fluorescence in situ hybridization, confocal imaging, intraductal ultrasound, or even EUS with FNA. So there's no shortage of options here. And really the question is, how do we get to the answer the quickest and simplest? So general standard ERCP tissue sampling, this is a meta-analysis of 9 studies with 730 patients, and I would argue this is probably about as best as you could do. So they found that brushings were 45% sensitive for malignancy, which I think is probably generous. I think most studies would suggest it's more in the 20 to 30% range. Intraductal biopsies around 48%, and even if you combine the two together, it's about 60%, which means that you're going to miss at least a third of the cancers, even if you do both of these things, okay? So that is obviously suboptimal. So then the next question is, what if, instead of in addition to standard brushings and biopsy, what if we do cholangioscopy? So there was a variety of modifications in cholangioscopy. So the original system, they're all single-use devices, had a fiber optical channel. This is no longer available. We then subsequently have sort of this digital single operator system, which allows, I think, also a little bit easier tissue sampling as well by passage of the forceps. So this is a little bit like your vision pre and post getting your cataracts fixed, I think. So you have the original sort of view on the left here, then you've got digital view on the right, and then there's actually some important features. That's actually a malignant stricture on the right there, and you can see the nodularity, you can see some vessels there. And I'll come back to this, but I guess visual accuracy probably, I'll say it over and over again here, is probably the single best predictor of malignancy. And so tissue is important, it is an important issue, but really careful inspection of what you're seeing is probably equally important for both diagnostics and targeting your biopsies. So there's been even more improvements on that, and this is not a malignant stricture, but I'm just kind of showing you, you can see the flange of a biliary stent that's been migrated, and here we are taking it, but you can look at the level of resolution that we now have, and this is almost comparable in some ways to sort of what we're seeing in the luminal view. So we actually can get very fine views now of the duct, and I'll come back to seeing whether that helps us actually in making diagnoses. So what is the role of cholangioscopy in indeterminate biliary strictures? Well, it can provide a visual diagnosis. It can potentially allow you to target your biopsies. And then something that we've been using it for is that we actually, in patients like this who do have a likely tumor, we actually try to go up above the bifurcation of both sides to see if we can see if there's direct extension. It's been my impression that sometimes MRCP either misses extension or falsely calls extension, which is actually due to sludge and obstruction. So it can both over and understage these lesions. And then occasionally it can use to directly access a small opening, which will allow for selective duct drainage. So what are these visual criteria that I'm talking about? Well, I think the big one is these sort of engorged tumor vessels, neovascularity that occurs. You may see polypoid masses, you may see papillary or villous projections, you can sometimes see infiltration with ulcerating lesions, and sometimes a very stenotic cholangiocarcinoma. And again, just like an ulcer in the stomach, you would biopsy the margins of this. Biopsying right in the center of the ulcer is going to have a very low yield. These are some of the pictures of cholangiocarcinoma. These are all malignant strictures using the old sort of fiber optic system. And these are some pictures of this is a picture of what we see some of the classic findings. So here's your stricture. Here is some nodular tissue. Here is some increased neovascularity with vascular lakes. And these are sort of, these tumor vessels. And so I'll just show you a whole bunch of pictures of malignant strictures here. And you can see they kind of have this fluffy type of appearance, and there's a lot of erythema, and you can see a lot of vessels here. And that's sort of your general sort of initial impression of these sorts of things. Again, here it looks a lot paler, a lot smoother. You don't see as much nodularity, you don't see as many vessels, and these are all benign strictures that you can see. So what about using cholangioscopy to take biopsies and target them, and then comparing that to standard ERCP sort of brushings or biopsies? And as you can, this study here from Florida looked at 26 patients. They did targeted biopsies with cholangioscopy, then did cytology brushings, followed by standard forceps biopsies. And they only considered an actual cancer, so you couldn't call suspicious for cancer as a positive. You had to have cancer. And when you use that criteria, you can see brushing is pretty terrible. It's 5.8% in terms of sensitivity. Standard forceps were 29%, and targeted biopsies were actually 76% sensitive, and the overall accuracy is 84%. So clearly there's an advantage to sort of using optically guided biopsies. Now, what about in PSC? Again, this is a meta-analysis of 21 studies, and I wouldn't focus necessarily on the numbers. I think the brushing numbers here are actually quite inflated. They did include suspicious as a positive in this sort of analysis. But again, cholangioscopy with biopsy still comes out on top compared to even confocal imaging or FISH, for instance, in situ hybridization. So it still comes out on the top here. Here's some sort of single operator. This is, again, a single center study from India. And again, they found that of the 36 patients, they correctly identified 21 of 22 cancers and 11 of 14 benign lesions. They overcalled 3 benign lesions as cancers, and they had an overall accuracy of 89%. But they used both visual and biopsy accuracy. Their visual accuracy was 89%, their biopsy accuracy was 82%, going back to this theme that I'm bringing up. Here's a meta-analysis of sort of cholangioscopic biopsies and indeterminate strictures, and you can see the pooled sensitivity, is around 60% here, okay? So again, even with all this, you still potentially could miss up to a third of cancers with sort of according to this meta-analysis. Again, the pooled visual sensitivity, however, was 84% and 82.6%, which, again, this is a systematic review that we did with the group at Northwestern. And looking at this, you can see that visual accuracy was 89% and the biopsy accuracy was 79%. So there is between a 10 to 20% increased accuracy by using the visual criteria as opposed to biopsy. So you're really using your biopsy to confirm what you already believe by what you see. And this is one of the rare times in medicine we'll say, trust your eyes more than the biopsies. So again, this is another sort of series of analyses that have looked at the same issue, showing again, visual impression sensitivity and specificity is improved compared to histology. And so despite the title of my talk, when it comes to specifically cholangiocarcinoma, tissue may not entirely be the issue, but of course our goal is to still try to get tissue accuracy. Diagnosis. So again, what if, I showed you that optics have improved. With improved optics, do you tend to get better yield compared to before? Our own internal data suggests possibly, again, it's a fairly small study, 40 patients, but we were able to ultimately have an overall sensitivity for malignancy of 85% and an overall accuracy for benign versus malignant of 32 out of 34 and 94%. And this is something we presented a couple of years ago. So I mentioned the issue about potentially using this sort of information for staging to try to figure out if a lesion was going up the right or up the left system, which can be important in determining surgical management. And again, this has now been studied. This is a group of 9 centers, 118 patients, most of whom had cholangioscopy. And they found by doing this, they were able to change the surgical plan in about a third of the patients. And again, that applied to the bile duct. Sometimes it led to less extensive surgery, but in many cases it actually overstaged the patients and maybe avoided a surgery because of extension that was identified more accurately. And the overall correlation between endoscopic and surgical histology and staging was around 88%. So this actually, I think, has some potential. So emerging applications, there are a variety of things that have been looked at. Certainly you can send your specimens from brushing for fish analysis. Confocal laser endomicroscopy is a promising tool primarily to rule out cancer. It tends to call a lot of things with features consistent with cancer. So it's highly sensitive but not specific, but the good use of that is its negative predictive value is good. So if it looks normal on confocal, it probably is not malignant. So I think that's one potential rule for that. Some of the others I think here are still not quite ready for prime time. So intraductal ultrasound allows you to actually put an ultrasound probe right within the duct and take a look. Again, these, we don't use this as much. You can look at to determine an infiltrating mass. You can look at it for suspicious lymph nodes. Because of cholangioscopy now, it's a little bit like saying if you can do a colonoscopy, why would you do a sort of a barium enema kind of thing? And so we don't need this radiologic test as much. But these are the kinds of images that you can get. Here's the duct, here's our probe, here's an infiltrating mass here, although it doesn't really seem to extend. You can see there's a vessel nearby there, probably the portal vein. So these are the kinds of images that you can get. Now, the other thing you can also do is actually do direct EUS, and you can see the bile duct here, which is a little bit of a thick wall here, and here's an area of bile duct wall thickening. This is probably the stricture, and again, you can see the portal vein, you can look for nodes, and we detect a major intestinal involvement, ascites, celiac lymph node involvement, or liver mets, and you can do tissue sampling, both of the duct, as you can see here, you can see a needle actually sampling in the duct wall, or into lymph nodes around. Now, if you look at EUS for indeterminate biliary strictures, overall it has a sensitivity about 75%. Distally, it's about 81%. Proximally, Hilar, it's around 59%. But there's a big concern about EUS-FNA and tumor cell seeding. In fact, so much so that any kind of transperitoneal biopsy, whether it's CT-guided or EUS-guided for Hilar strictures, can essentially exclude a patient from transplant candidacy. So if you're going to do something like this, you really want to consult with your hepatologist and transplant surgeons to make sure this patient might not be a candidate someday for that. Because if you do this up front, you may be taking an important potential option away from your patients. And this is because you can see here, patients who had undergone no FNA had poorer outcomes compared to those patients who had had an FNA in patients with cured intent with surgery. So I'll close by saying what's our algorithm here at UCLA. The first question is, does a patient have an underlying condition that may predispose them to a benign stricture like PSC? If that's the case, and we're really concerned about malignancy, we typically start with an ERCP with brushing or biopsy. But again, that's the definition of an indeterminate stricture, is that you probably already had one of those. So we typically go straight to cholangioscopy with biopsy with or without fish. If there's a low clinical suspicion, an initial stricture that was brushed and it was negative, we may just leave that alone and follow them in surveillance with MRCP. Now, for non-PSC patients with a distal stricture, the concern is that there may be a pancreas cancer. In those patients, it's very appropriate to do an EUS-FNA. And then if you need to stent that patient, you could also get brushings or biopsies if you don't have an answer. And then if you still don't have an answer in the future, you could do cholangioscopy with site-directed biopsy. But the yield of EUS-FNA here should be excess of 90%. For proximal strictures, Hilar cases like Dr. Kim's presenting here, really ERCP with brushing would typically done first, but if it's non-diagnostic and you have an indeterminate stricture, I think the correct answer, as you correctly answered, was to do a cholangioscopically directed biopsy with or without fish. And I would reserve EUS-FNA only for adenopathy for staging. And if you're going to primarily biopsy that lesion, make sure the patient's not a transplant candidate. Thank you.
Okay, so the patient undergoes ERCP with cholangioscopy and biopsies, as many of you guys chose to do in our last question here. And so on cholangioscopy, we see this tumor mass growing in the bile duct near the hilum. You can even see the openings to the right and left hepatic ducts here. During the ERCP, you manage to place guide wires into the right and left hepatic ducts with a lot of difficulty. So here's a picture of the cholangiogram with wires in the left and right. And then during the ERCP, then you selectively do a cholangiogram over the guide wires, which shows mild to moderate intrahepatic bile duct dilation. Again, here's the cholangiogram. I'll orient the wires here if I get the mouse. So here's the wire in the right duct. Here's a wire in the left. And then a little bit of contrast into each duct showing that there's some dilation there, much like you saw in the MRCP. And these procedures can obviously be very complicated. So the question for the group, what is your plan for biliary decompression in this patient? A, ERCP with unilateral plastic biliary stent placement. B, ERCP with unilateral metal biliary stent placement. ERCP with bilateral plastic stents. ERCP with bilateral metal stents. Percutaneous transhepatic biliary drain. Or do nothing, refer to surgery first. Right, remember you have wires in the left and right already. All right, so I guess over half you pick C, ERCP with bilateral plastic stents, and then I guess someone picked one of the other answers, each of the other answers. All right, so to discuss this topic, which I think is can be tough both technically and from a clinical standpoint, we have Dr. Keswani discussing biliary stenting and hilar cholangiocarcinoma, musings of the endoscopist.
Just use the forward key. All right, thanks. So I'm going to sort of go through this, and this is a dense topic. So I'm going to sort of things that I think are really the key points here. I'm going to try to highlight a couple of times, and I'm going to try not to get bogged down in excessive data. So I think just the things that I think would be really relevant for us to think about, I'll sort of say a couple times. So the outline that I thought of when I was given this topic is really four questions. One is sort of the cat's out of the bag. Raman was so excited to do the ERCP, he's already done it, so we can't even talk about this first question as much. Should we do the pursued drainage at all? But we'll discuss it anyway. 2, should ERCP be the mechanism of drainage? 3, should we stent both lobes or one, and then plastic or metal? So I think we're going to hit all the topics that Stephen was asking me to think about. So should we pursue drainage at all, right? That's the first question. And that's often the one when you work at a tertiary center that we don't really have that option anymore. Someone's already intervened upon the patient, or they have stents already in place. So we need to think about this, all of us who perform ERCP. So the rationale for pursuing biliary drainage is that if you have biliary obstruction, and you go to surgery, for example, the obstruction leads to coagulopathy and post-hepatectomy liver failure by impairing the regenerative capacity of the liver. This is the same reason we think we should pursue preoperative biliary drainage for pancreas cancer, which is also controversial. And there's data that suggests that if you have a higher bilirubin before surgery, that negatively impacts your postoperative outcomes. But the idea is that we're really trying to decompress the part of the liver that may be there left over after surgery, right? There's no point in stenting a part of the liver that's going to be removed in a week or two. All that said, we really don't know whether preoperative drainage improves outcomes, and if it's beneficial, really what's that jaundice cutoff where we really need to pursue it or not. So for me, when I think about pursuing ERCP or any preoperative biliary drainage in a patient like this, I think of three questions. One is one that Raman talked about. Is this a determined or indeterminate stricture? And so tissue acquisition may be requested before surgery is considered, and once you're in the duct, there's no questions anymore, right? So once you have those both wires in, and you've opacified both systems, you must drain those systems. So the cat's out of the bag again, you have to sort of proceed. That being said, I think we need to understand the caveat that tissue acquisition is not perfect. So if you have a high index of suspicion and for a malignancy, and ERCP, whether it's positive or negative, is not going to change that suspicion and the ultimate outcome of surgery, you need to really ask yourself if ERCP is going to be adding a lot, because you are then introducing infectious risks into the patient. And the second is disease resectability, which was touched upon. The reality is most patients we see with these hilar malignancies are going to be non-surgical patients. Often many of them that I'm seeing in my practice are actually metastatic disease, even more than primary cholangiocarcinoma from lymph nodes from colorectal cancer. And these patients obviously require palliation of their jaundice. It's not really a question of surgery or not. But I think it's important, the caveat that Raman touched upon, is that not all obviously resectable malignancy is actually obviously resectable. The extent of disease, in my experience, is often underestimated on MRCP. MRCP is great at vascular involvement as well as triphasic liver CT, but it's pretty difficult to assess the extent of involvement in the bile ducts. So I think it's important to understand that imaging resectable hilar cancer doesn't mean it's actually resectable. And many studies go about this. None of them do it very well because it's a hard area to study. But fluoroscopy itself, so the ERCP itself, can really underestimate the extent of hilar disease in about half of patients, right? And so that's where this cholangioscopy question comes in. And once again, you've made that decision. You've had that discussion with your surgeons. Hey, I want to figure out how much it's creeping up into the intrahepatic ducts. Once you're in there, then you've got to stent the patient. And then the third thing we need to think about is the disease location. In resectable hilar disease, you need to think about how much liver will be left over post-surgical resection. So what do I mean by that? About 2/3 of the liver volume is in the right lobe and 1/3 is in the left lobe. And we think from pretty good data that if you're going to do a right hepatectomy, that you really want your left lobe to be sort of working optimally afterwards, and that means probably a preoperative stent. So put that in a different way from this study. Patients who underwent a right hepatectomy who were jaundiced at the time of right hepatectomy had about a 7 times odds ratio of dying post-surgery. And dying is obviously the negative outcome we all want to avoid, right? And so if you're going to be left with a smaller amount of liver volume post-surgery, you want to do whatever you can to make that part of the liver work optimally. And that includes preoperative biliary stenting. And that isn't as clear for left-sided hepatectomies where you're going to have a large right lobe liver volume left over after surgery. So what's currently happening in this space? This is an analysis of 900 liver resections using the NSQIP database. And it basically looks at, again, does preoperative biliary drainage negatively or positively impact outcomes at 30 days? What you need to know is that the people who get preoperative biliary drainage are the people you'd expect to get it. The people who are tend to be more jaundiced, tend to have more hilar tumors, and are more likely to have a major liver resection. Overall, preoperative biliary drainage is associated with increased postoperative complications. So people who get either ERCP or percutaneous biliary drainage tend to do worse after surgery than those who don't. So it's the idea where the endoscopist or the radiologist makes things worse than better. But for this sort of subgroup of patients we're talking about, which are the really challenging one, these Hilar cases, there's really no data that preoperative interventions has any real adverse effects. It only increased the risk of need for blood transfusions, which seems just sort of a spurious finding. It had no significant difference in bile leaks, need for invasive interventions, or liver failure. All that said, it also didn't make patients better, right? So you need to think about before you pursue that biliary drainage, are you going to make a positive impact? So who do I think should get preoperative biliary drainage in likely resectable disease? If you have an anticipated large volume liver resection, so a right hepatectomy, extended right, extended left hepatectomy, or if you already decided you need to perform that ERCP for diagnostic purposes. Who should likely get ERCP? Patients who are deeply jaundiced, partly because you're probably missing the extent of disease on imaging, or if you have multiple comorbidities, because these patients will probably get slow rolled towards surgery, and that longer duration of jaundice will probably negatively impact their health. So if you've decided that biliary drainage should be performed, the next question is, should it be us as the endoscopist, or should it be percutaneously? And this is an area it's actually very challenging to study as well, unfortunately. The best data we have is this Dutch study of 4 academic medical centers, and despite sort of having a very well-run randomized trial, they were able to enroll 54 patients over 4 centers. And what they did is they basically randomized people with resectable-looking hilar cholangiocarcinoma to either percutaneous biliary drainage or ERCP. And what they basically said is a successful procedure is that we reduce your jaundice some, and then your bile ducts look less dilated on imaging. And they have to screen a ton of patients to get to that 54 patients who look like they have resectable disease. So what are the outcomes that we all need to think about? One is that most of these patients have more complicated hilar tumors. And we'll talk about the bismuth classification again, just for sort of committing to memory. Nearly a third of the patients who come to this trial already had stents in place of some sort, either percutaneously or endoscopically. The technical success and the therapeutic success were better with percutaneous biliary drainage, right? So interventional radiologists were able to get into the ducts of interest and palliate jaundice better than the endoscopists, but the other sort of negative for endoscopic drainage, half of the people who underwent ERCP for these cases ultimately needed adjunctive percutaneous drainage. So this is high volume centers running sort of the best trial we have, and still, despite that, about half the people needed some sort of percutaneous drainage in addition to ERCP. So why is percutaneous drainage not taken over ERCP? Well, the adverse event rate was similar between the both groups, but they actually had to prematurely terminate the study because cholangitis was higher in the percutaneous group, and the mortality rate was higher in the percutaneous biliary drainage group compared to endoscopic. So everything was favoring percutaneous except, again, death, which favored endoscopic. So what does that sort of mean? It means that basically endoscopic will likely remain your first choice, but understand that about half the patients will end up needing some sort of adjunctive measure. We tried to study this in a large U.S. multi-center study called the Intercept study, and essentially got terminated due to slow accrual. Essentially, no one was able to identify the patients, get them at the right time before they had ERCP or percutaneous biliary drainage. And after enrolling 13 patients at 20 sites, essentially the study was terminated. The early data wasn't looking so good either. I mean, the successful biliary drainage, only about half of people in either group had successful biliary drainage, and only a quarter of people had complete relief of their jaundice. So why am I showing you this really negative data? This is a very hard area to study and intervene upon. These patients have complex stricturing disease. These are not your typical distal bile duct strictures, and you need to really work in a multidisciplinary group. There's a lot of other sort of low-quality evidence out there that sort of conflicting data saying IR is the best, ERCP is the best. Really, this is not one case where one physician can solve all problems. So the best evidence so far to answer this question of percutaneous versus endoscopic biliary drainage, based on that sort of level 1 evidence from the Netherlands, I think it's appropriate to start with endoscopic drainage when possible. But you got to preoperatively tell people this is a more challenging set of procedures, and that up to half of people might need a percutaneous drain in addition to ERCP. And I think it's important to understand that all of these patients, endoscopic or percutaneous, likely have high adverse event rates. So I'm going to sort of run through the next two questions more quickly because they're a little even less data. So if ERCP is performed, should we drain one lobe or both? I think it's important for all of us to understand that, in a patient with normal liver function, they don't become jaundice until both lobes are obstructed, right? So I think it's very important to get that high-quality MRCP and CT to assess your drainage options. And I think that patients with two functioning lobes, like one lobe is not completely atrophic, if you have two functioning lobes, like I think we saw on the imaging that Stephen showed us, that it's perfectly appropriate to try to drain both lobes in a patient for palliation. But if you have a specifically atrophic or chronically obstructed lobe on imaging, this is very important, don't touch it. Don't try to get contrast in there, so what we generally do endoscopically is I will preoperatively look at the MRCP, say, I want to get the right lobe, and I will selectively get the wire into the right lobe and never inject contrast into the left lobe at all. Because there's no benefit in getting to that left lobe, and once I'm inside of it, I'm obligated to drain it, right? And so you must drain any obstructed segment that is injected, but you should try not to inject any chronically obstructed segment that is atrophic. Again, one of these things to just sort of put into memory if you're doing ERCP is the bismuth classification. It's a nomenclature that's easy to learn, and it sort of helps you communicate with your surgeons and referring doctors. So the bismuth 1 are the easy ones. Those are the ones that are sort of basically acting like our pancreas tumors. These are ones where the common hepatic duct is obstructed below the bifurcation. In this case, you place a stent across the stricture. It'll drain both sides of the liver without an issue. A bismuth 2 strictures, where the stricture is going up to the takeoff of the right and left hepatic ducts. And in these cases, we generally will try to drain both the right and left lobes because they generally are both functioning lobes. But in contrast, the 3A strictures, where the disease is going deeper into the right intrahepatic ducts, where the takeoff of the anterior and posterior system, this might be one where you say, I'm going to just drain the left lobe. That's the one that's less likely to get recurrently occluded with tumor ingrowth. And similarly, for the 3B, you might decide to just drain the right lobe. And then bismuth 4, if you can sense that it's a bismuth 4 before you get to ERCP, this may be one you say that ERCP may not be the best option at all because you're dealing with a lot of subsegmental stricturing. And so to have that idea before you get into the procedure, or at least be able to communicate it after your ERCP can be helpful. So there is a randomized trial showing whether bilateral or draining both lobes versus unilateral drainage is better. And there is a signal to that draining the right and left lobe when possible. It has better clinical success and is less likely to require reintervention. I will say this doesn't really impact my care as much. I will, again, try to drain both lobes if I think they're functioning well. Otherwise, I think draining one lobe is fine. Because there's really competing data and meta-analyses which show there's no difference between the two, right? So there's one high-quality study that says draining both lobes is better, but then a lot of low-quality meta-analysis data says that, that just at least drain one well. So my approach is to drain at least the dominant non-atrophic lobe. For bismuth 2 and select bismuth 3 tumors where both lobes appear to be functioning, we should try to drain both sides. And in the final minute, I'm going to answer this other question, which has the least quality data. If ERCP is performed, should we use plastic stents or metal? In this case, it's a very, very, very easy question. The answer for this particular case was plastic for sure, because you cannot stent with metal if someone may be surgically resectable for hilar tumors. Pancreas cancer, yes, but for hilar tumors, you should never put metal in until you're 100% sure your surgeon has signed off that surgery is not an answer. The advantage of plastic is that we can remove them, we can more easily treat multifocal obstruction, but the thought is that the durability of the metal stents is higher. And we think that in meta-analysis data that the durability of metal stents is better, but I really, really, really am wary of metal stents and hilar strictures. You cannot remove them. These patients live for a long time, and I've found that they're much harder to intervene upon. So although the data would suggest that metal is better than plastic, my approach is I will use metal for bismuth 1, which are those common hepatic duct obstructions, and really easy bismuth 2s, where there's really just focal extension into the left and right hepatic duct. But when in doubt at all, I will use plastic stents, because you can always redo plastic, you just cannot redo metal. So I'm very, very cautious about metal for hilar tumors. So in summary, I think you should judiciously choose whether ERCP is needed. We cannot undo the choice, right? Once you're in there, you're stuck with whatever you've done. I think you should consider the depth of jaundice and how much remnant liver will remain after surgery to help you make that decision. ERCP should be the initial approach for drainage for most hilar cases, but understand that nearly half of patients will require percutaneous drainage. There's no clear need to drain both lobes, but certainly drain the dominant lobe. And there's conflicting data regarding plastic and metal stents, but I always choose plastic when in doubt. Thanks again for the invitation.
All right, so based on the MRCP and the ERCP cholangiogram, you suspect that he has a bismuth 4 malignant stricture. You're successfully able to place bilateral plastic stents over those wires that were placed into the left and right hepatic ducts. The patient actually does well and is discharged home. So the patient returns to clinic a week later to discuss the results from the procedure, right? You did cholangioscopy with biopsy, bilateral stenting. He now comes back to clinic. You inform him that the pathology is consistent with adenocarcinoma, and he is depressed. And he's referred to oncology. But after he gets home, he starts reading the internet, and he comes across a rather new treatment option for cholangiocarcinoma called biliary RFA. And he calls you to ask, do you think I should be referred to UCLA for biliary RFA for treatment of my cholangiocarcinoma? And what is your response? A, yes, because RFA will make you live longer. B, no, because RFA is new but unproven. C, maybe, because the indications for RFA are not clear to me. Or D, I don't know what you're talking about. Stop reading the internet. All right, so there are a lot of questions here. 44% of you said maybe, because the indications for RFA are not clear. And 30 you said no, because it's new and maybe not very well proven. So to discuss this topic further, we have Dr. Ali Sedarat. We're talking about the role of biliary RFA in the management of cholangiocarcinoma, what, when, and how.
All right, good morning. Okay, so what is radiofrequency ablation? It's a means of applying an alternating current to raise the temperature of target tissue and induce an effect, a thermal injury that once it gets hot enough, there's coagulative necrosis and cell death. And there's the obvious direct therapeutic benefit of ablating whatever you're touching. And indirectly, there's some evidence that when you cause necrosis of the tumor, that the intracellular components are released, and there's an immunogenic sort of exposure to the immune system and to chemotherapy, and there may be an improved outcome in that way. And so that's what we're talking about. When we're talking about biliary RFA, the main technology available is the hepatobiliary RF probe. There's another probe that's not available in the United States that I think is a Korean company. But the Habib probe is what we have. It's an 8 French catheter. It's placed over a wire. If you look at the picture here, there's a leading tip and then these 2 stainless steel electrodes. And there's a sort of an insulated middle, and the ablation length is this 25 millimeters around these kind of stripes that you see, and it extends around 3 to 4 millimeters deep to the catheter. So when you're done ablating, you get an ablation zone of about 2.5 centimeters long by maybe about 1 centimeter wide, just to kind of put it in perspective. And use about 7 to 10 watts of a coagulation effect for up to 2 minutes. So how do you do this? You get your wire in, you dilate the stricture if you need to, if it's super tight and you don't think you can advance the catheter. You advance the catheter and you hook up your generator. There's a bipolar adapter cable. The settings are soft coagulation effect 8. Depending on where your target is, whether it's in the common duct or above the confluence, it's either 7 or 10 watts. And with the most common generator that's used, it's a 90-second application. And importantly, you have to just kind of wait and sit and do nothing for a minute before you move the catheter to avoid kind of avulsion of tissue. And if you need to, if you have a longer stricture, you can withdraw or advance and apply again to cover the length of the stricture. You may balloon sweep if you want to extract some of the dead tissue, and then you always have to stent after ablation. So what are the applications? It's kind of an interesting paradigm shift or a different approach than what we do usually in endoscopy for cancer. If you think about it, most of the time we're diagnosing and we're fixing plumbing, right? I mean, that's pretty much what we're doing, except maybe for the early cancer resection with very strict criteria or precancerous lesion resection. So we have an opportunity to really treat the cancer itself, which we don't necessarily have that opportunity very often in an interventional endoscopy. So we can do this for malignant biliary strictures as adjuvant therapy to stenting, and so we're talking about bile duct cancers or cholangiocarcinomas, pancreas cancers, and potentially other cancers that may be metastatic to the bile duct. Treatment of occluded biliary stents, meaning that there's a metal stent in place and there's ingrowth of tissue that's occluded, and perhaps you can burn that tissue that has occluded your stent. After ampulectomy, often one of the concerns after ampulectomy, if there's a little intraductal extension that evades your snare, there's descriptions that are emerging of ablating that successfully. And there's a few case series of benign biliary strictures, which I would say at this point is mostly just investigational. So as we do this, what should we be looking for? Why do this? Well, the obvious answer is survival and overall and progression-free. If you're just doing it because it sounds like a good idea to burn the cancer and you're not really providing a survival benefit, it doesn't justify the risks of what you're doing. Stent patency is important because stent patency and in a palliative setting, relief of jaundice and maintenance of biliary drainage is associated with survival, so stent patency is a good outcome. And in terms of quality of life and duration of patency of a metal stent, being able to effectively occlude someone who previously had, to treat someone who previously had a metal stent that became occluded is important. These are cholangioscopic pictures of a pre and post RFA. So this is pre and this is post. And you can see the sort of effect of the lumen diameter. So I put together a little bit of data to go over. This is a very nice review that if you're interested in this topic, you should take a look at. They looked at a bunch of different data, but in that subset of malignant biliary strictures, they looked at 12 studies which involved 318 patients. And there was only one RCT, and most of these were retrospective type of studies. And most of them all of them in fact showed an improved stent patency of some significance, whether that was clinical significance or not, you could argue. And some of the studies showed survival. But there were some pretty significant side effects, more than perhaps we would be used to dealing with in regular ERCP. There was pancreatitis, cholecystitis, cholangitis, hemophilia, including a couple cases of fatal hemophilia, and there have been anecdotal evidence of hepatic artery pseudoaneurysms, portal vein injuries that in a delayed fashion have led to some pretty bad outcomes. And so the suggestion is, although there's only one RCT, that this technique is not without cost and there is some risk above standard ERCP. The one RCT that we have available is from 2018, 65 patients followed for a couple of years. Importantly, they excluded type 3 and 4 patients, which are really the ones that we are talking about for this case, but it's the only RCT that we have. And they looked at RFA plus plastic stent versus plastic stents alone, and they demonstrated improved stent patency and survival. with similar adverse events in both groups. So that's the only RCT that we have. So the data that we have for this method is poor, unfortunately. So when you have poor data, what do? You try to put it all together. And there's a meta-analysis of 500 patients, 9 studies with a biliary stent and RFA. And this included both endoscopic and percutaneous drainage. So you can imagine that if you can put a wire percutaneously, you can also advance the catheter percutaneously, done outside of this country more than in the United States. But they also demonstrated with this meta-analysis improved stent patency by up to a couple months, and improved survival, although you could argue that survival clinical significance may not be all that much. The only significant adverse event that they could find was more abdominal pain in the RFA group, and that I would say is my experience as well, as I'm sure in this panel, that pretty much everyone that I've had RFA in recovery, they make you a little bit more nervous than the standard ERCP patient. They often have chills or rigors, fevers, pain, things like this. Overall, if you look at this data, the adverse events, although low, are generally higher than for standard ERCP, cholangitis, sepsis, cholecystitis, liver abscesses, abdominal pain, pancreatitis, and the bleeding complications have been rare, though enough to give you pause. When was the last time you caused a fatal hemophilia? And so there was 3 reported in this series, 2 of which were fatal, which is a big deal with something that may or may not have a clinically significant benefit. So when should you consider RFA for Hilar Cholangiocarcinoma? The first is you should really kind of counsel the patient about its role, and you should think to yourself, what is this patient's ultimate goal? Are they eligible for transplant? I think that should be for especially Klatskin type tumors, biliary, 3s and 4 bismuth types. That should be one of the first questions that we ask even before we do the ERCP. Is this patient at some point going to go to transplant? And you don't want to be the person that eliminates that option from the list of therapies, even if they haven't gone through that evaluation. And so you can imagine if, let's say you do the RFA and they get a cholangitis and a liver abscess that just makes them too sick to get a transplant, or even worse, they have a hepatic artery pseudoaneurysm that Dr. DiNorcia wouldn't want to anastomose reasonably. So I think that's a very important question, and that has not been a question that has been answered. It hasn't been looked at in the literature in this subset of patients. And arguably, that's the only method that we have for this subset of patients to provide a cure. Are they at risk for bleeding? If they're on anticoagulation, for example, or have a significant coagulopathy, arguably you may want to be very careful. It may be worth reviewing the imaging and seeing, is there a major vessel near where you're going to potentially ablate? And these are considerations that, normally in ERCP we don't have to even think about. Where's the portal vein? Where's the hepatic artery on the CT scan? You have to teach yourself to look for that. Maybe someone who you've seen over a long period of time and they just don't make it to their stent exchanges like you want them to. So someone who has plastic stents, you're exchanging them every couple months, 2, 3, 4 months, but they always kind of don't quite make it. They end up getting hospitalized with a little bit of low-grade cholangitis before their outpatient appointment. Maybe that's someone to consider. Maybe you should just do it in everyone. I mean, you could also make the argument that there's randomized controlled data that there's improved survival and stent patency. And if I'm asking that many questions, the answer is that we don't know, right? And so we have this technology, and it's a technology in search of an indication, and we should strive to figure that out. I think a case-by-case basis is really the way to do it. So what do we need? We need more studies, confirmation of the improved survivability with an emphasis on safety. We need to figure out its role in the modern era of chemotherapy and immunotherapy, its role in the transplant eligible or pre-transplant setting. What's the repeat protocol? Do you just do one RFA session, that's the only one that you get? Do you get repeat applications every time you do a stent exchange? Do you do an RFA, put a metal stent in, put a plastic stent in? How do you do this? Better technology we need to kind of talk about. The catheter will only burn what it touches, as opposed to a balloon or a PDT type technology. So the tissue apposition and effect is not necessarily as predictable as we would like. There may be a dosimetry that needs to be worked out. We kind of base 7 watts and 10 watts and 90 seconds based on very little data. So a lot of unanswered questions. Thank you.
So you tell the patient, maybe not RFA at the moment. Patient goes back and scours the internet some more. And he reads that he could be a possible candidate for liver resection or even liver transplantation. So now he's excited. So another ARS question for the group here. All the following statements about liver transplantation for Hilar Cholangiocarcinoma are true, except which of the following? A, the lesion must be single and less than 3 centimeters in size. B, the candidate must undergo neoadjuvant therapy with systemic chemotherapy, external beam, and transluminal radiation. C, the patient must have a transperitoneal biopsy to confirm malignancy to be a candidate for transplant. Or D, the patient must undergo operative staging to exclude regional hepatic lymph node metastasis and extrahepatic disease. All right, so most people selected C. The patient should not, right? So it's true, the question is true except, so the patient should not get a transperitoneal biopsy, and that was briefly mentioned in Dr. Muthusamy's talk, as well as Dr. Keswani's, I believe. And then a bunch of other answers. So I think there's a lot of questions out there about who are the appropriate candidates for liver resection and transplantation. So who better talk about this than Dr. Joseph DiNorcia from our liver transplantation team.
Okay, good morning, and thanks for the invitation to talk today about the surgical management of Hilar Cholangiocarcinoma. Just as an overview, I thought first we'd review some of the anatomy because it's really the understanding of the anatomy that'll help us define resectability. And then I'll talk a little bit about what we as surgeons think about when we're evaluating a patient and preparing them for surgery. And we'll review a little bit of the resection options and finally talk about liver transplantation for Hilar Cholangiocarcinoma. So the liver is actually composed of 8 segments, each with its own portal, venous inflow, hepatic artery inflow, as well as hepatic venous drainage and biliary drainage. And it's this segmental anatomy of the liver, as well as the liver's capacity to regenerate, that allows us to actually resect parts of the liver and leave enough left for patients to still survive. And what you can see from this diagram is the main bile duct. The first order branch would be the right hepatic duct or the left hepatic duct, but then as we get into the right anterior segment or section or the right posterior section, those would be the second order bile ducts. And this is important to understand when we're talking about options for resectability. So when we're talking about cholangiocarcinoma, there are 3 main types, intrahepatic and distal. And this talk, I'm going to focus mostly on the hilar cholangios, which arguably are the most complicated to deal with, and I'll explain a little bit why. The intrahepatic cholangios we can most of the time remove with just a liver resection, whereas the distal cholangiocarcinomas we can remove with a pancreaticoduodenectomy or Whipple procedure. But the hilar cholangios, depending on their extent of involvement either with the distal bile duct and the hepatic parenchyma, most often are going to require a major hepatic resection. And in very aggressive centers, we might even do a major hepatic resection as well as a Whipple in order to achieve negative margins. So in this 2D diagram, we can understand why the hilar cholangios are such a problem, because the bile duct's bifurcation sits in this high traffic area where the hepatic artery and the portal vein bifurcate, and as we extend into the first and second order branches of both the vasculature and the biliary tree, we start to involve the hepatic parenchyma. And these are some figures from the Toronto Video Atlas, which is actually a free website if you're interested in seeing some really great videos about what's involved in resection. I highly recommend looking at the website. But you can see from 3D reconstructions the real challenge with these hilar tumors. In this bottom right-hand corner, We can see that this is a bismuth 4 type tumor. It involves mostly the left side of the biliary tree, and we can see that the tumor really interdigitates with the second order branches of even the hepatic artery and the portal vein. This patient actually was able to undergo a resection. It was an extended left resection that left them really with only the right posterior section of the liver, and they required multiple biliary anastomoses to second order bile ducts. And the final piece of anatomy that I want to review is the caudate lobe. It's sort of like the Bermuda's Triangle of the liver segments. It's segment 1, and it has 3 basic portions: this caudate process, the paracaval portion, and the lobe that sits on the left side of the vena cava is called Spiegel's lobe. And the caudate lobe sits right behind the bile duct and the bifurcation of the hepatic vasculature. And the reason that the caudate lobe becomes so important with the hilar tumors is because it has variable biliary drainage, where there can be up to 6 bile ducts that drain into either the left or the right hepatic ducts, or sometimes both. So when we're thinking about resection, there's good data to suggest that even if we see a lesion that involves mostly the right hepatic duct, the best way to achieve a negative margin is to take out the whole caudate lobe, and because of this variable biliary drainage is the reason why. So this point has sort of been hammered home already, but I thought I would just quickly review the classifications for hilar cholangiocarcinoma. The types 1 and 2 are most often resectable with just a bile duct resection, and then we can reconstruct the bile duct with a hepaticojejunostomy. It's the type 3s. 3A will extend up into the right hepatic duct, and type 3B will extend into the left hepatic duct. These are the ones that we're talking about. We'll need the whole bile duct resected, as well as the involved lobe of the liver and caudate, and then we'll need to reconstruct the remnant bile duct with a Roux-en-Y hepaticojejunostomy. And then the type 4s involve the second order bile ducts on both sides, or have multifocal involvement of both the intrahepatic ducts and the extrahepatic ducts. These are not resectable, but I wouldn't say that they're not treatable. These are the patients that may be candidates for liver transplant. So when we're evaluating a patient for surgery, some of the themes that we're hearing is the hilar cholangiocarcinomas can be very challenging to diagnose. And I think that in the process of evaluating a patient, we need to be thoughtful where we're keeping both options of resection and transplantation in mind, so that we don't do anything in the workup of the patient that would exclude either options. Things like a transperitoneal biopsy or metallic stents, which we've heard about. And I also wanted to say that we only need the minimum diagnostic criteria to pursue either resection or transplant for these hilar tumors. We don't necessarily need tissue. So the minimum that we need is a CA19-9 and really high quality cross-sectional imaging of the chest, abdomen, pelvis to adequately stage the patient. And the goal of the imaging is to rule out any distant metastases, but also to define the tumor and how it relates to the biliary tree and the vasculature of the liver. And I think an important point to emphasize is before we drain the biliary tree, we really need to get high-quality imaging. Often the patient will come to the emergency room with jaundice and get maybe a non-phased CT scan. We see intrahepatic biliary dilatation, and they go right to drainage before we get the high-quality imaging. The importance of the imaging before biliary drainage can't be understated, because often we don't see a mass, and we sort of use the dilation of the biliary tree to understand which ducts are actually involved. So again, just to hit the point home, that pathologic confirmation is not necessarily required prior to pursuing resection or liver transplant evaluation, provided that we've already excluded any of the benign etiologies and that we've properly staged the patient. And a point that we want everybody to take home is that we shouldn't ever pursue a percutaneous or a laparoscopic biopsy of the primary tumor because of the risk of seeding either the biopsy tract or the peritoneum, because that would effectively exclude the patient from transplantation. So once we've evaluated a patient, what are some of the principles of surgery? And I think the basic principle of resection is that we want to get the whole thing out with negative margins, and we want to complete a regional lymphadenectomy, not so much for treatment, but just so that we can properly stage the patient. And in order to get the entire tumor out, it's usually going to require a major hepatic resection, a lobe or even an extended lobe, because we need to take out the entire biliary tree and the caudate lobe, as well as the half of the liver that's involved, if we hope to get a margin negative resection. And the other important principle is what we leave behind. The contralateral liver needs to have adequate volume, but also intact arterial and portal inflow, and we need to have biliary reconstruction options for the side that's left behind. So when we think about what's resectable, the goal, again, is to remove all the intra and extrahepatic bile ducts, as well as the associated hepatic and caudate lobes, but leave enough remnant liver for the patient to sustain life. So in order to consider resection, these are the requirements. The patient needs to be medically fit to undergo a major operation. They need to have minimal underlying liver disease. It needs to be anatomically feasible. We have to stage them and rule out metastatic disease. There needs to be adequate future liver remnant, and we need some sort of biliary reconstruction options. Unfortunately, despite our best efforts, all our preoperative imaging, we can deem a patient resectable, but at the time of exploration, 20 to 50% will end up being found to be unresectable. So even though we do a complete preoperative assessment of the patient, it doesn't eliminate the risk that we may end up performing a non-therapeutic operation or even an incomplete resection. This is an MR from a patient who we think is most likely resectable, and what we can see is there's a mass lesion or stricturing right at the bifurcation that seems to extend over to the left side. This is the left hepatic duct. But the right hepatic duct, both the right anterior and posterior duct, is likely free of tumor. So we plan to do a resection on this patient, take out the entire left lobe and entire bile duct with caudate, and hope that we can get a negative margin here on this right hepatic duct. Unresectable is a little bit easier to understand, and it's this may be a little bit complicated, but we just have to think about is there a way to take out part of the tumor with leaving adequate liver behind? So if bilateral segmental ducts are involved or bilateral vascular inflow to both sides of the liver involved, that tumor is unresectable. If we have one lobe that's atrophic and the other side of the liver has segmental duct or vascular inflow involvement, we can't obviously resect that patient because we'd be taking out the good lobe and leaving an atrophic lobe. Or if we have one side where the duct is involved and the other side where the vasculature is involved, that patient is unresectable. This is a patient that Stephen and I actually had a real hard time evaluating and working up. This CT scan, we can see that there's a mass, there's no real mass, but we can see duct dilation extending all the way into the second order ducts. This is an isolated segment 4 duct, isolated segment 2 and 3 duct, and anterior and posterior right hepatic ducts. The challenge with this patient was he came to us with 2 percutaneous drains in the right anterior and the right posterior ducts and metallic stents in the left bile duct. So in order to get tissue, when Stephen went in to do the cholangioscopic biopsies, there was a lot of inflammation, ingrowth into the metallic stent. It was very difficult to get tissue. We ended up having to go through one of the percutaneous biliary drains to get tissue. So if we determine that a patient's resectable, there's a lot of thought that goes into the perioperative preparation, and most of it involves how do we optimize the future liver remnant. And we have 2 strategies. One is portal vein embolization, if needed, to hypertrophy what remnant liver will be left, and also to decompress the biliary tree on that side, a little bit of what we heard about. And that can be done either endoscopically or through a percutaneous transhepatic biliary tube. So the future liver remnant is what's left behind, and it's defined as the ratio of the volume of the liver remnant to the total liver volume, but we do have to interpret it in the context of the patient's underlying liver function. So in a patient with normal, healthy liver, they need about a 20% future liver remnant, and there's pretty good data to show that if you leave the patient with less than 20%, they have increased risk of morbidity and mortality and post-hepatectomy failure. If you have a patient who's undergone chemotherapy, so they have chemotherapy-associated steatohepatitis, or a patient with underlying fibrosis or NASH, we need a larger future liver remnant, around 30 to 40%, and we assess this with our preoperative imaging and volumetrics. And we can actually get really nice pictures nowadays with the technology, with CT 3D reconstructions. And if we see that the future liver remnant isn't enough, we can send them to interventional radiology, and they can embolize the portal vein to the side that's going to be resected in order to induce contralateral hypertrophy. And these are just some good images that this was a patient that was going to undergo a right hepatic lobectomy, but the left lobe wasn't quite big enough. They had right portal vein embolization, and after 4 weeks, the total volume of the left lobe went up to about, I think, We have it here about 800 grams, so 46%, which is more than adequate. So I won't spend too much time on biliary decompression, but there are two schools of thought. Those who say decompress everybody, note improved liver function, decreased postoperative complications, but the opponents say that it increases infection rates, risks tract seeding, and there's not good data. But I would say if a patient is jaundiced and they have cholangitis, are going to undergo neoadjuvant treatment to become a transplant candidate, have malnutrition secondary to hyperbilirubinemia, any hepatic or renal insufficiency, or if we're going to try to induce hypertrophy, those patients should definitely get decompressed with the goal bilirubin of less than 3 before we resect them. And again, the point is do not put in a metal stent. So based on the segmental anatomy, we can do different types of resections. We can take out the right lobe, which would be segments 5, 6, 7, and 8. Extended right would include segment 4. We could do a left lobe, which is 2, 3, and 4, and extended left would also include segments 5 and 8. We can take out the middle sections of the liver. It all depends on the anatomy of the tumor. In the OR, first we'll put in a scope to make sure that there's no metastatic disease and evaluate all the peritoneum. And if there isn't, we open up and we still need to confirm local resectability by doing some dissection in the hilum to understand whether or not the tumor involves the vasculature to the remnant side. I'm running a little bit short on time, so I don't want to emphasize, re-emphasize too much, but the goal in the operating room is to take out all of the involved liver in the hepatic duct. We may end up needing to do some arterial reconstruction or venous reconstruction. We do perform a regional lymphadenectomy, and we send frozen sections from the proximal and distal bile duct margins to be sure that we got it all out before we reconstruct the bile duct. I won't spend too much time on this, but if the vasculature is involved, it doesn't mean that they're not necessarily a candidate, especially at a center where we do transplant. We have the techniques where we can take out a portion of the artery or the portal vein and reconstruct it. It just requires some thoughtful preoperative planning. So what are the outcomes for resection? It really depends on the margin and the lymph nodes. There's no role for debulking. So if we're going to try to resect, we try to get all of it out. And we can see that the survival curves really fall down, and initially it's really based on the T stage of the tumor. So as the tumor involves more of the bile duct and the surrounding vasculature, the survival really falls down, and any patient with lymph node involvement, their survival is quite poor. So I'll just quickly finish with liver transplantation. It sort of makes sense because we can really achieve a tumor-free margin if we take the whole liver out and put a whole new one in. It treats the parenchymal invasion, and it will also treat the underlying liver disease. But the limitations of liver transplant are really bound by the organ shortage. We're in an area of liver scarcity, so not every patient who needs a liver can get one. And initially, after transplant was pursued for even hilar or intrahepatic cholangiocarcinoma, the outcomes were dismal. We've actually gotten much better. So who's a candidate for transplant? They really need to be a candidate for liver transplant by standard criteria, so cardiovascularly and respiratorily fit, have adequate social support, psychologically fit. But the main difference is that the patients who have hilar cholangio need to undergo a protocolized neoadjuvant chemoradiotherapy regimen prior to transplant. And before we take an organ and put it in, we do have to do an operative staging to exclude any regional lymph node metastases, intrahepatic mets, or extrahepatic disease. This is important, and I'll just quickly run through it. This is straight from the guidelines on the website for UNOS about who's a candidate for transplant. So you can see that we don't actually need tissue. If a patient has a diagnostic criteria for hilar cholangio with a malignant appearing stricture on imaging, they only need one of the following: either a biopsy or cytology that demonstrates malignancy, a CA-19-9 that's greater than 100 in the absence of cholangitis, or if they demonstrate abnormalities by FISH analysis. They must be considered unresectable by technical considerations or underlying liver disease. The mass needs to be single and less than 3 centimeters, and they must not have had a transperitoneal biopsy or any type of biopsy that would have violated the tumor plane. The outcomes for transplantation are actually pretty good. The 1, 3, and 5-year survival from single center studies are about 80 to 60%. And when we look at some meta-analyses of whether we should pursue transplant versus resection, the data is not great, but some of the meta-analyses would suggest that transplantation has better survival than resection. This is 1 and 3 year overall survival compared between resection and liver transplant, and you can see that the plot analyses tend to suggest liver transplant, but again, the data is not that great. So just to summarize the key points, the standard therapy for hilar cholangio with resection isn't that great. It's about 35 to 50% with an R0 resection. Unfortunately, most patients are unresectable. In selected patients who are ineligible for resection, they can undergo neoadjuvant chemoradiation followed by liver transplant and have pretty good survival. We do need to get quality imaging prior to biliary decompression. We have to avoid a biopsy that violates the tumor plane, avoid metal stents, and I think early referral to a tertiary center with hepatobiliary surgery and liver transplant is the best way to avoid excluding a patient for transplant or resection candidacy. Thanks.
You mentioned 20 to 50% of the people you take to the OR are unresectable. Is that due to sort of patients who are 3A, 3B being 4s, or is it more anatomic vascular type things? What's the most common reason that's the case?
Yeah, I mean, there's a couple things. Often we will put the scope in and see that there's actually small intrahepatic mets. I think that's one of the main reasons. Often, if the scope looks fine and we open up, once we start the hilar dissection, we see that the contralateral portal vein or hepatic artery is really involved. Sometimes it's hard to distinguish inflammation from tumor, but without getting yourself into trouble if you take a piece of the tissue. But I think the most common reason is metastases, and then the second is like just locally invasive to the point that we can't resect.
Can I a quick question, Dr. DiNorcia, as well? We stress out a lot about getting tissue diagnosis, and it was interesting to hear you emphasize that you didn't need it. The protocol for transplant, does it require neoadjuvant therapy?
Yeah, the protocol for transplant does require neoadjuvant therapy. So I know that was maybe a little pie in the sky to say that we don't need tissue, because the oncologist won't treat the patient unless they have a confirmation of malignancy. So I tried to say that we don't need tissue before we initiate the liver transplant evaluation, and then in the process we can get it.
Great.
And then a question for you as well. Any preference towards something like a triple phase CT scan versus an MRI liver with a specific gadolinium-based contrast in terms of what's most helpful to you in terms of determining diagnostic or therapeutic plan?
I think they're both really good. I think it's a personal preference. I think the triple phase CT helps us define the vasculature pretty well. So I prefer the triple phase CT. We usually end up getting both so that we can get the MRCP component of the MR so that we can see the bile ducts a little bit better. But I think it really doesn't matter. As long as we get a high quality cross-sectional imaging, whether it's MR or CT, it doesn't really matter.
All right, so there were plenty of questions from the panel here, so we'll just move on for the next section. All right, so we'll just finish out this case. Repeat imaging shows stable tumor, but new evidence of carcinomatosis and ascites. He's no longer considered a candidate for liver transplantation, unfortunately. He started on a different chemotherapy agent, given the progression of his disease, and then he continues to undergo ERCP every 3 months with RFA and bilateral plastic biliary stents. And here's his patient. Each time he comes in, this is before his RFA procedure, but you can see the stricture there involving the bile duct, the intraluminal narrowing. He gets RFA, and this is a cholangioscopy done right after the RFA is performed, and you can see the necrosis caused by the RFA. And again, here's kind of before and after.